everybody, my name is Sinead Hutcheson and I'm here to talk to you today about transition in palliative care. I'm going to talk about what the fellowship was that led to this presentation, tell you a bit about what is transition. I'll tell you about the site visit to a Children's Hospice Trust that I went on, what I learned from being there and future developments in this area. So the All-Ireland Institute of Hospice and Palliative Care developed education fellowships last year. These were short-term fellowships to facilitate development of skills, capacity and leadership. They were up for a value of up to €2,000. This was to pay for your travel, accommodation and subsistence while you're away. And the purpose of them was to provide an opportunity for individuals to engage, learn and enhance their knowledge about innovative palliative care and to develop collaborations. So I applied for one of these along the theme of transition. So what is transition? Well, the most commonly used definition was published in a journal called Adolescent Health in 1993. They describe it as the purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from child-centred to adult-oriented care. My personal interest in this was really just because I come from a GP background, and through that training I'd done a fair bit of paediatrics and a little bit of community paediatrics, and I always sort of wondered where that group of patients would fit into what we do in palliative medicine. So who transitions? There are two phrases used to describe the groups who transition. There's life-threatening conditions and those with life-limited conditions. The life-threatening conditions are those for which curative treatment may be possible but can fail. So this is the group where we have malignancies and organ failure. The second group is a much broader one. It's described as conditions for which there's no reasonable hope of cure and from which the patient will die. So these include progressive conditions without any curative treatment, such as the muscular dystrophies, and the irreversible but non-progressive conditions which cause severe disability that can lead on to lots of other health complications and increased likelihood of premature death, such as cerebral palsy. So why is transition relevant? Well, we know that there is a group of young people who previously would have died in childhood who are now living into their early adult years and beyond, and this is really due to medical advances. We now have things like ventilation, artificial feeding, improved surgical techniques, which has meant that these young people are living longer. We have figures to support this. There's a piece of work done by Fraser et al. In 2011. They looked at routinely collected hospital inpatient data all across the UK over a period of 10 years to look at the prevalence of children with life-limited conditions. And if you pick out the data just for Northern Ireland, they found that the prevalence had increased in those 10 years from 23.5 per 10,000 to 27.8 per 10,000 population. So small numbers, but they are on increase. And if you look specifically at the 16 to 19-year-olds within that number, they had the biggest increase. They had increased by 33% over that time period. I don't have the same data for the rest of Ireland, but the figures were roughly similar across the whole of the UK, so they're probably roughly the same in the rest of Ireland. So why does it matter? There's some evidence that poor transition will lead to poor health outcomes. I think one thing we need to remember is that we're talking about looking after teenagers, and so they're going through a very emotionally challenging time. They may be getting increased independence from their parents. They're a group of people who are heavily influenced by their peers. They may be experimenting perhaps with risk-taking behaviour, and all of this can lead to non-adherence to medications and possible lack of engagement with health professionals. There was a paper in the BMJ last year called Bridging the Gap. It's a really interesting paper that looked at the transition of young adults with kidney failure from paediatric to adult services. They compared two groups. There was the first group who were transferred between the two teams in the traditional way, which was a single referral letter from the paediatric to the adult team. The second group had a targeted integrated transition service. This group, they had specific young adult clinics. They had employed a youth worker who met with the patients individually and as a group of peers. They had the clinics outside of the hospital in a sort of youth club setting. In the first group, almost 70% of these lost a functioning renal transplant within 3 years of transition. And in the second group, there were no transplant losses over the same period. Now, it was really small numbers, so it probably wouldn't be statistically significant, but I think it just does highlight that good transition has got positive outcomes. It's also important because it's very high on the political agenda. Marie Curie and Together for Short Lives created a report called Don't Let Me Down. This report had gathered the views of young people and their families who were going through transition. And in it they made recommendations to government to try to improve the move to adult services. This report was presented to ministers at the House of Lords last year. Following on from this was the formation of the Transition Task Force. This is a strategy group with representatives from each of the organisations listed here, and their aim is to improve transition services. Where did I go on my trip? Well, I looked all over Europe for somewhere a wee bit more exotic than Birmingham to go from a week away, but really the UK and Ireland are really leading the way in terms of transition. I don't think anyone is doing anything different or better than what we're doing. And if you Google transition palliative care, you'll come across Acorns somewhere within the first page. Acorns is a children's hospice trust in the West Midlands of England, and they provide a network of care for life-limited and life-threatened children and their families. They've got 3 10-bedded inpatient units, which provide respite, emergency care, end-of-life care. They also have a large network of community teams. They provide family support and bereavement support after death. So I went for my visit for a week in April. During that week I visited each of the 3 hospices. I met with various members of staff, including the CEO, who's also the chairman of the Transition Task Force. Spent time with the transition team. I spoke with one of their young ambassadors and attended a Transition Task Force meeting in London. In terms of learning outcomes, I think one of the sort of big, broad learning outcomes was what a children's hospice actually does and how it differs from adult services. A children's hospice acts as an umbrella organisation where the patients and their families have easy access to everything that they need. I think then it becomes a huge culture shock when they move into adult services and there's all the different areas of health, psychosocial care, education, none of whom may necessarily communicate with each other. People have been quoted as saying that the move from paediatric to adult services can feel like standing on the edge of a cliff, about to fall into a black hole, and having the sense that you're off the radar after the age of 19. So I think in this context, the obvious person to coordinate the care and advocate for the patient is the GP. But for this group of patients, they may not have ever accessed their GP or may not have accessed them for years. A lot of these patients would have direct telephone access to either their hospital consultant or a nurse specialist, and they may be able to have direct access onto a hospital ward. So they really don't have a relationship set up with their GP. Excuse me, that's fine. Another broad learning outcome is to think about the different journeys that these young people have been on. A lot of these children have been unwell their whole lives and may have been using the facilities of a children's hospice since birth. It's quite different to the adults that we see in adult palliative medicine, quite different to the people we see in adult palliative care, who have generally had a long period of good health and who then have a very catastrophic diagnosis. Also in adult palliative medicine, in general, we have some idea of a disease trajectory, whereas with the children, it can be very, very unpredictable. They may have periods of stability with lots of serious events in between, and some can have unexpected deaths. Some of these children will have very unusual diagnoses, and some of them may not even have a formal diagnosis, so we don't even have a disease trajectory to be able to predict. So how do they do it at Acorns? Well, their transition team pilot began in 2010. It started with a single staff member and grew to the current staff of 4, 1 full-time and 3 part-time. Currently, the transition process starts at the age of 14. They have separate interviews with the young person and their parents. They come up with a plan of different things that they want to achieve. If, for example, that young person's thinking about going to college, they hand over some of the responsibility of finding out about that to that young person. So they have to go off and look into it and then come back and are supported through the process. During the transition process, they look at education, housing, independent or supported living, advanced care planning, respite options and care at home. They have developed a transition model which just helps to guide staff as to which bits fit in where, acts as a trigger to remind them what they need to be looking at and where we should be linking in with adult services. They also have a transition subgroup from the West Midlands Paediatric Palliative Care Network. There are representatives from both the adults and paediatric side on this. Links are being developed with various care providers, and they are forming a database of this to be able to refer their patients on to care providers that they know and trust. They provide education to adult services if and when required. They also have an adolescent team who work very much with the young people in preparing for adulthood. And they have a group of young ambassadors. This is a group of young people who are either going through or have been through transition, but who continue to work with Acorns on a voluntary basis to sort of help improve the services. So I think that makes it sound like quite an easy thing to do, but there are a lot of challenges. I think firstly, the big one is who to refer to. If we're talking about medically, a lot of these children will have been under the care of a community paediatrician, and we don't have the equivalent of that in adult medicine. And adult medicine is generally very specialised now, so you may be able to find a cardiologist who will look after the patient's cardiomyopathy, but not a general physician to take on the care of a young adult with cerebral palsy. As I mentioned before, the lack of contact with primary care can make things difficult. Managing expectations can be a big one for the patients, parents and staff. Patients can have very high expectations of the care that they need, and they're used to a very personal, tailored, one-to-one care, and they move then into adult care where it's all ward-based schedules can be very, very different. In terms of this group of parents, these parents have expected their child to die in childhood, and suddenly they have a young adult in front of them who, obviously depending on cognitive ability, may be wanting to move out of the house and go to college and do normal things. Parents may have continued to treat that young person as a child despite advancing years and cognitive ability, and that can lead to challenges when they move into the adult world and health professionals are targeting all the questions directly towards the young person. In terms of the staff in the paediatric teams have built up relationships with these young people over many years. They have probably expected to look after them up until their death, and so maybe reluctant to let them go. And staff in the adult teams may feel anxious about looking after patients with diseases they may never have come across before. As I said before, just working with adolescents probably adds a bit more complexity to the situation. Funding, when does a child become an adult, and therefore what pot of money will funding come out of to cover all this? And also when to get involved. From a service provision point of view, a lot of these young people will be very stable at home and may not need much intervention. But when you think back on the journey that they have been on, I think that the patients and their families are likely to want intervention early on, just so that they can get to know staff, form relationships and build trust. So what next? What is happening in the world of transition? Well, there's lots going on. ACT, which is the Association for Children's Palliative Care, have developed a transition care pathway, and this can be used locally to develop your own care pathway. The Transition Task Force are working on raising awareness and influencing policy and commissioning. There is some research going on. There was a big 3-year project called the STEP project, which looked at evidence of positive practice for young people going through transition, and the results of that are being disseminated across the UK this month. In terms of education, there are multidisciplinary study days about caring for young people with palliative care needs run through the University of Wales. And it has been suggested that staff exchange or shadowing could be helpful for people working in this area. When I was at Acorns, I spoke with one of their young ambassadors who was a 24-year-old young man who'd been through the process of transition, and I asked him his advice for those of us working in adult palliative medicine. He had lots of advice to give me, but probably the biggest message he had was to try to find a common ground between adult and paediatric teams, and one that also involves the patient. And I think that is a goal that we could all work towards, to try to improve the care for this small but very important